Good morning, everybody. At the outset, my sincere apologies for slightly dislocating this program. Unfortunately, we are 40 minutes late. Now, 900 seconds is obviously impossible for one to talk on M2M, even in the very restricted area of healthcare. I will try to take you with me on a journey which I'm absolutely sure every one of us is going to go through. When I got interested in M2M a few years ago, I thought my grandchildren will be able to see this. I never ever thought that I would live to see this. Today, ladies and gentlemen, you know that the 7.5 billion Homo sapiens in this world has got competition. And today we have 18 billion mobile-to-mobile interconnected devices. The statistics are overwhelming. Probably in the next few years is going to become even more. Creating tomorrow's healthcare, I think the new era is beginning. The world is on the move. Yesterday I read in the newspaper TRAI's report that 76%, is unbelievable, 76% of internet in India, a developing country, third world country, etc., is being accessed through the mobile network. This is India today, local statistics. I always believe that one industry which is absolutely recession-proof is the healthcare industry. Even if the economy goes down, I can live without cars, I can live without air conditioners, but ladies and gentlemen, whether you like it or not, you have to go to a hospital before you are born and even after you die, because your stem cells and even sperms and ova can be used. So this is one industry which, if the M2M enthusiasts ignore, they are doing it at their own peril. Today, 14% as per statistics of M2M is for the healthcare industry, and this is going to steadily increase. I love this American phrase DIY, do it yourself. And on the lower left-hand side of the screen, you can see an ultrasound being done by a patient himself. Gone are the days when blood sugar used to be done by somebody, and today we have point-of-care diagnostics, which I'll show you in a minute. Cholesterol, triglyceride, lipid profile, the whole works can be done. I personally am very happy that in a few years I certainly will not be practicing medicine because I don't think I'll have a job at all. The entire healthcare ecosystem, as you call it, is changing. The healthcare is being taken out of hospitals. And today, your pocket is being converted to a laboratory. Your pocket is a hospital. Hospital at home. A hospital in the future is going to be the last step, perhaps to do a liver transplant, perhaps to do a cardiac transplant, certainly not for evaluating even blood pressure or diabetes. All this will be at the comfort of your home. Riding the ICT wave. Information and communication technology is what is going to change the way healthcare is. And I'm particularly happy that India is not at all in the back. We are not even piggybacking the West. We are actually leapfrogging. 10 years ago, it would have been impossible to have medical doctors like me on the adjunct faculty of IIT, Anna University, etc. The distinction between medicine and engineering and technology and ICT is becoming less and less, and this is what is going to happen. But I am concerned. I belong to the BC era, before computers and before Christ are one and the same. I was the last neurosurgeon in this country who was trained before the CT scan came. Sometimes with enthusiasts like you, no offense meant, it is because of people like you that M2M has come what it is today. Are we developing a technology and going in search of an application? I think it should be the other way about. The healthcare provider like me should come to you and tell you, sir, this is what we want, please help us. But today I think it's the other way about. I didn't realize that this audience are M2M experts, so I just put this, that in the field of healthcare, what is M2M? We use a device. This could be as implanted or it could be a surface sensor. This captures an event. Let's say blood pressure, blood sugar, EEG, ECG, ENMG, etc., etc. And this signal is relayed through a network. The network could be a wired network, could be a wireless network, could be a hybrid network, to an application, a software program that translates the captured event What does it matter to a doctor when I see hundreds and thousands of the so-called big data which everybody is talking about? I mean, I don't want 10,000 blood pressure recordings per day, which is what your sensors are now giving me, which is what your programs are now giving me. All I want to know is my patient a hypertensive or not? Should he be treated or not? And therefore, this useless data, I need to take out what is significant, what is meaningful in this, and this is be analyzed by a AIS or an artificial intelligence system, and later on only this goes to a physician, where the physician introduces corrective measures. Of course, as I mentioned earlier, we're going out of a job, and today it is not even brought to the notice of the physician. You have algorithms and flowcharts which determine that when insulin is to be released from a depot pump preparation which is implanted into your body. A one-to-one connection is changed into a system of networks that transmit data with reduced power, reduced time for intercommunication. Wearable technology. It is foreseen that this is going to be the next big innovation in healthcare. And again, wearable technology is already being done in bits and pieces, even in India. When anything new is developing, we love to use the word pilot. Personally, and I can talk with some authority, I think there are more pilots in telemedicine, digital health, e-health than there are in the Indian Air Force. I think we suffer from a disease called pilotitis. We are very successful in doing pilot studies, proof of concept validation, but we are just unable to make it a part, to escalate it, to make it a part of the healthcare delivery system. The slide on the right, again, as I said, I shudder to think how people of my generation are going to practice medicine. I can't even understand half the words here, and this is how medicine of the future is going to be. Now, again, a report which says that this year alone, 90 million wearable devices in healthcare. Just think about it. 90 million wearable devices are being exported. We are not talking of forecasts. We are talking of this year in 2014. And what are these wireless implantable devices? Delhi, Chennai, Thiruvananthapuram, Bombay, Bangalore, Ahmedabad. I can rattle off at least 15 centers in India today which do deep brain stimulation, where we put an electrode inside the brain for Parkinsonism and other conditions. Again, we have a host of other technological devices which already are being used in India, but of course the numbers are very small. It's just a question of time before the numbers become bigger and bigger. Now let's look at the world market. The size of the balloon says it all, and you can see that in the healthcare is probably the largest. Healthcare and medical is the single largest area where M2M devices are being going to used. Of course, this brings in its wake lots of problems. We are now talking of privacy and security. You all know about Snowden. You know how they end the Obama's the National Defense Council in the United States itself was invaded by hackers. Today we are worried that a pacemaker which is implanted inside you, if I don't like you, I just get a geek and he does a software program and he can wirelessly alter the way in which the pacemaker functions. So we are now talking of security for implanted wearable devices and how does this function, etc. It is as per the present statistics, Chennai, where I live in, 2040, which is not too far away. Hopefully I'll still be alive. So in 2040, every fifth person in the city of Chennai is going to be above the age of 60. Senior citizens. 1/5 of India are going to be senior citizens by 2050. And at the moment we have 1 million centenarians. And this probably is going to become much higher. So what does this mean so far as M2M is concerned? With a geriatric population, you are going to have smart homes. Today, smart homes are a reality, particularly in Northern Europe, Australia, and several other countries. In India, the traditional joint family is disintegrating. My children are in the US, and it's very unlikely that when we become older, we will have anybody to look after us. And more you find smart homes. I don't have time to go into the details, but this is what it is. Contact lens. Would anybody have dreamt? Of course, there is a lot of hype in this. I'm not saying no. But then This may take several years to become a reality. Google themselves have said it will take 5 years before it becomes commercially viable, but then the writing is on the wall. Wear a contact lens, and the contact lens will automatically, wirelessly send not blood sugar, but send the sugar values in your aqueous humor, vitreous humor, in your tears, etc. And without your knowledge, a server somewhere, God knows where, will make out that the sugar values are higher and will give instructions to a depot preparation which is implanted in your thigh to release the appropriate antibiotic. This is not science fiction. This is already happening. Google Glass is becoming used more and more in operation theaters to transmit it, and you can see there are so many things like this. Non-adherence, non-compliance is a major issue seldom spoken about in the management both of diabetes, seizure disorder, hypertension, in fact all chronic diseases. The NCDs, or non-communicable diseases, are going to be the major factor why India's GDP is not going to increase. And this is relatively simple. To ensure compliance and adherence, you have a sensor, you have a chip, and if you don't take the tablets in time, you will get a message that you have not taken the tablet. Not only that, when your tablets are being consumed, at the end of the day, it's all ROI, it's all vitamin M. Or every one of these things happen only because somebody gets a dividend. At the end of the day, we are all hypocrites. We are not interested so much in wiping the tears of suffering humanity. It sounds nice to listen to all this, but at the end of the day, it's ROI, ROI, ROI. That's what you want. And here, automatically a signal goes to the neighborhood pharmacy. The pharmacist is told that such and such a capsule in such and such a place, GPRS, you know exactly where it is, a refill is due, please go and fill it up, and that is how this adherence is ensured. 10 years ago, I said that the stethoscope would die. Nobody ever believed me, and I have published this in a paper as well. Last couple of weeks, there are several papers which have shown that over the next 4 to 5 years, maybe 10 years, certainly the stethoscope will no longer be a symbol of the medical profession, what has been a symbol for 200 years. Why? Because why do you want to make a cardiac or a respiratory diagnosis by hearing sounds? You may be having wax in your ear, you may not be able to hear it. Today, thanks to M2M, you have absolutely fantastic devices which can do an echocardiogram, which can functionally evaluate the competence of the atrium, the ventricle, the oxygen in the blood, the venous blood and the arterial blood. What used to be done in big laboratories and big hospitals today is available at the bedside. And again you can see a wristband which transforms a wearer's heartbeat into a unique password, and this is what is going to happen. All this is already happening. Will my grandchildren be like this? I don't think so, because I think my children are going to be like this. I don't think I have to wait till my grandchildren to become like this, and this, whether you like it or not, is going to happen and be a part of the way in which we dress maybe 10 or 15 years from now. Again, just to show you that I'm not talking theory, I'm not talking science fiction. About 8 months ago, I introduced what we have patented it as ICU. Today, at the Apollo hospitals in Chennai, at the main ICU, where we have 120 beds, the largest ICU in the country, 29 of the cubicles have been fitted with a networked camera, and today we are discouraging physical visits to the ICU. People from all over the world, of course, we have put in a very high level of privacy and security. Only authorized people can make these virtual visits, but an authorized person from anywhere in the world with an internet connection can switch on the camera, pan, tilt, zoom, focus, do that, do this, etc. And more than 800 people have used this, and there's very little of human intervention. 915 million mobile phones in this country. 20% of them are smartphones. What better way to deliver healthcare than through this? And already the technology is available. Your phone can literally prevent blindness. Again, it is Indian students, it is Indians who are doing this everywhere. At Harvard University, an Indian group at Boston MIT, they have developed this program so that you can do your own optometry, you can prescribe your own glasses and so on. For lack of time, I am not going into the details. Now, you cough into a phone and get a diagnosis with acoustic vocalization software. So ladies and gentlemen, this is the future. I could go on and on, but I don't think it's fair for me to encroach on the time of others, and so I will stop with this. What is the take-home message? If I am to summarize my talk, the take-home message is, even at the cost of sounding, I don't know, obnoxious maybe, I would like to say there is no M2M without the healthcare industry, and M2M, whether you like it or not, is going to be an integral part of the healthcare industry. But please, please do not forget that at the end of the day, I don't like the word healthcare industry. I don't think we are conveyor belts. I don't think we are consumers and clients. I think we are human beings, we are patients. I still would like to think that the doctor 10 years from now practices TLC, tender loving care, and uses M2M as an enabler to achieve an end and not displace the doctor. Thank you very much for inviting me. If the moderator permits, if there is time, I can take a few questions. I mean, your decision.
Sure. We can take up questions.
Dr. Ganapathy, you have talked about cough as a diagnostic. In the traditional medicine, we have the tongue as diagnostic medicine, we have the eyes as diagnostic medicine, we have the pulse as diagnostic medicine, Nidana in Ayurveda.
Absolutely.
So you should use all those multimedia methods in the M2M to diagnose.
Absolutely. I totally agree.
Sir, my main question is, since you mentioned that it should be the other way around rather than M2M guys trying to create something for the healthcare ecosystem. What are the imperatives or your expectations from the M2M ecosystem as a healthcare professional?
Right. I think that one of the reasons why M2M has not permeated the healthcare industry, not just in India but worldwide, is the fact that the traditional healthcare provider, that is the doctor, is not being consulted, is not being encompassed, is not part of the team which develops all these fantastic devices you are doing. So with all respects to the brilliant technological minds, I attend so many conferences dealing with technology, with M2M, etc. And in one M-Health conference in Washington, there were 3,500 delegates, and out of which there were 20 doctors who were practicing. So 3,500 technologists decided what is the future of healthcare for the world in a 4-day conference. This to me sounds not the right way.
Mr. Ganapathy, I also wanted to know how much of this can actually reach the masses, because what all you told were very special extreme cases. But the
yes,
mass level health delivery,
yes,
particularly in the villages, because people don't have doctors in the PHCs. So how do we reach medical care to the remotest villages and poorest of the poor?
A very good question. Again, the cell phone is a typical example. The first phone which I bought maybe 15 years ago or something, the functionality was 1% of what I have now, and I probably pay 20 times for that now. So with mass production, with increased utilization, certainly the cost will come down, and as per the government, whichever government is going to come in by 2020, as per the National Telecom Bill of India, which is waiting to be passed, 100% of India's citizens are going to have access to information and communication technology by 2020. So mass utilization, costs will come down, and people need to be convinced that this is not a gimmick. Right now, a lot of people in the healthcare industry feel that this is a gimmick, and that multinational companies, to increase their revenues, are pressurizing us, forcing us to get into this. The initiative should, like a Quit India movement, I should go on strike and I say, I want this device. Until that happens, I don't think it's really going to take off.
No, but that brings us to another question, that when doctors themselves are not willing to go to the villages for the healthcare delivery, how do you expect technocrats and technology ecosystem to go down that? That is the first challenge that you guys have to look at.
I'll answer you very simply. Yeah. Today, geography has become history. Geography has become history. I don't have to go to the villages. No, but I can get the villager on a big screen. I can get him on my phone.
See, it's easier said than done. We still need paramedics, or we still need some people who understand something. Absolutely. The interface between the masses and the technology or the healthcare services, whatever.
So we are all
missing. That breed is missing.
You are absolutely right. Excellent point. We are just given a proposition to the government. We have recently been asked to provide healthcare through internet-enabled kiosks. You know about the CSC,
Yeah.
Common Service Center, DIT, Government of India, Department of Health. So we have given a proposal to, a beautiful word you used, to create a new breed called rural healthcare facilitator. We
Yes.
have designed the course content, but then the government is still, the papers are held up. So we hope to design and train, you're absolutely right, a new entity called Rural Healthcare Facilitator who belongs to the community, who is in the community. There is no way that I'm going to go and live in a village. But you're absolutely right.
Sure, thanks.
Sir, there is one question. Do you have any e-health course curriculum so that the e-doctors can be prepared?
Yeah, sorry, I don't know. I started a telehealth technology course 7 years ago with Anna University. We ran 5 courses and then stopped it because I'm not able to give employment. The simple thing is it's not commercially viable, and unless we give employment, people are not willing to pay fees. There is no such thing as a free lunch. If you are prepared to give me a couple of lakhs of rupees to run the course, I will do it tomorrow morning. So that's the problem.
I have a question, sir, Dr. Ganapathy. It's a very exciting field. I have just one question. Do you have any insight on what would the policy perspectives, to make this M2M ubiquitous or pervasive? What do you think from the point of view of...
We have a long way to go. Forget M2M. Even telemedicine, telehealth, e-health, digital health, it's happening. But we are a long way to go from policy. There are no regulations, there are no rules. I give consultation outside India. I give consultation all over India. I don't know whether I'm breaking any law. But there is no law which says I can't do it. There's no law which says I can do it. So I think in my lifetime, I don't think we are going to get regulations on M2M in India.
So we need to
Thank
come
you.
up with white papers.
Yeah.
Yes.
For the policy.
And since the industry is obviously much more powerful than the poor doctor at the other end, I suggest that you please take the initiative to do this.
Most will.
Thank you, sir. Great.
Yeah, so I would like to invite Mr. R.M. Agrawal to present a memento to Dr. Ganapathy.